presenting a very interesting topic today. Before we start, I would like to thank E-Physiocon for their efforts. So as I was saying, today I'm going to present a brief introduction of myofascial meridians. We all have studied anatomy in that we usually study muscles, bones, ligaments, joints, even visceral anatomy. But what we never study was fascia, which is a very important part of our body. Theoretically as well as practically, we physiotherapists work daily with fascia to treat our patients. So today, in my presentation, I will define fascia and how and where it is present in our body. What you see on the screen is the illustration of different fascial meridians. Meridian is an imaginary line drawn to demonstrate the path of the myofascia. Understanding fascia. Fascia has gone from being nobody to being the body's superhero. Fascia is the current biological phenomena that is receiving long overdue attention from body workers, athletes, medical professionals, especially physiotherapists, and now even from the researchers. The Fascia Research Society states fascia is the most pervasive but perhaps least understood network of the human body. No longer considered the scraps of the cadaver dissection, fascia has now attracted the attention of scientists and clinicians alike. Thomas W. Mayers of Anatomy Train says individual muscles acting on bones across joints simply does not adequately explain human stability and movement. The answer lies in fascia. In fact, fascia could be the answer to a lot of questions about structure, movement, stability, pain, and healing. Fascia is a web of connective tissue formed in bands that wraps around all the internal parts of the body from head to toe and fuses it all together. It allows the muscles to move freely alongside other structure and reduces friction. It can be found immediately beneath the skin, around muscles, group of muscles, bones, nerves, blood vessels, organs, and cells. Fascia is everywhere. Like bones, fascia bands are composed primarily of collagen, which gives them a tough but pliable texture. The facial system maintains a balance of tension and elasticity, which allows for smooth, unrestricted movement of each muscle group while holding everything in place. If the fascia is restricted, then muscle contraction is restricted. Restriction is where pain and injury can happen. Tight fascia is every bit as painful as restrictive as tight muscle. The picture you see is the extraction of fascia from the cadaver. In this picture, there is no muscles or bone. The cadaveric extraction of fascia is done to show how fascia is everywhere and connects everything. Dr. Thomas Finlay illustrated the complexity of fascia with this simple clinical demonstration. Sit in your chair with your knees bent and dorsiflex your ankle. Now, with knees straight, dorsiflex your ankle. The foot moves less. Now, bend your trunk forward and do dorsiflexion. Even less motion. This demonstrates one simple facial connectivity. Like a glove, fascia has enough substance to hold shape but not enough to support weight. This illustrates how movement and structure conditions such as poor posture affect fascia, causing pain and unstable movement. Every organ and system in the body has a job that only it can perform. However, none of it happens without the work of the body as a whole functioning unit. We can't effectively treat a distressed organ, system, or even a muscle without affecting the whole unit. So the answer is to treat the unit of the human being as a whole. The nature of fascia confirms this. Now, coming on to the different meridians or lines of fascia in our body. Superficial backline. Superficial backline connects and protects the entire posterior surface of the body like a carapace, from the bottom of the foot to the top of the head in two pieces, toes to knees and knees to brow. When the knee are extended as in standing, the superficial backline functions as one continuous line of integrated myofascia. These are the following demarcations seen in the superficial backline. Superficial backline originates from the underside of the distal phalanges of the toe. It includes plantar fascia and tendons and muscles of toe flexors. Fascia attaches to the collagenous covering of the calcaneus. At this point, the fascia continues up with the Achilles tendon. Moves up with the soleus and the gastrocnemius towards the knee when the knee extended to myofascial continuity provided by the hamstrings up to the ischial tuberosities. There is no muscle attachment at the ischial tuberosity in the direction we are moving forward, but there is sacrotuberous ligament comes from the back of the tuberosity demonstrably as a continuation of hamstring. From the sacrotuberous ligament we have erector spinae. Back line travels over the top of the skull on the Galea aponeurotica or the scalp fascia and firmly attaches to the frontal brow ridge where it ends. There you can see the whole superficial back line scrapped out. Next we have is the superficial front line. The superficial front line connects the entire interior surface of the body from the top of the feet to the side of the skull in two pieces, toes to pelvis and pelvis to head, which when the hip is extended as in standing, function as one continuous line of integrated myofascia. Here again you can see the demarcations of the superficial front line on a human body. The overall postural function of the superficial front line is to balance the superficial back line and to provide tensile support from the top to lift those parts of the skeleton which extend forward of the line of the gravity. The pubis, ribcage and face. Myofascia of the superficial front line also maintain the postural extension of the knee. The muscles of the superficial front line stand ready to defend the soft and the sensitive parts that adorn the front surface of the human body and protect the viscera of the ventral cavity. The superficial front line originates from the top of the toes, then it moves further to the peroneus tertius originating from the fifth metatarsal. Then we have tibialis anterior, which passes under the extensor retinaculum. Then it moves up to the tibia, fibula and the interosseous membrane, continuing straight up to the quadriceps where it involves only the rectus femoris. Now we ride up the abdominal fascia, the muscular elements of pyramidalis and rectus abdominis, and the facial layers that surround the rectus from the obliquus and transversus. So it continues up to the fifth rib. From there it moves up by the sternal fascia along with the fascia underlying the pectoralis major. Then the superficial front line moves up with the sternocleidomastoid. It moves laterally and posteriorly to the mastoid process and onto the posterior lateral Galea aponeurotica. The superficial front line tracks back along the neck onto the post portion of the temporal bone and asterion, as you can see in the image. Next we have is the lateral line. Lateral line brackets each side of the body from the medial and the lateral midpoint of the foot, around the outside of the ankle and up the lateral aspect of the leg and thigh, passing along the trunk in a basket weave or a cross shoelace pattern under the shoulder to the skull in the region of the ear. The postural function of the lateral line is, the lateral line functions posturally to balance front and back and bilaterally to balance the left and the right. The lateral line often acts to stabilize the trunk and legs in a coordinated manner to prevent buckling of the structure during the activity. On the right side of the screen, you can see the lateral line. Again, there is a demarcation of the lateral line on the human body, and you can see the crisscross or the cross shoelace pattern in the thoracic region depicted by the green color line. Lateral line starts with the first and the fifth metatarsal bases, moves up to the lateral side to the peroneal muscles, which then moves up to the fibular head. From there is an attachment to the anterior ligament. Then it attaches to the iliotibial tract, moving further to the tensor fasciae latae and then to gluteus maximus. From the ASIS and the PSIS, the fascia continues with the lateral abdominal obliquus. Then in the thoracic region, it runs with the external and the internal intercostals. Then it finally ends with splenius capitis and sternocleidomastoid. Next we have is the spiral line. The spiral line loops around the body in two opposing helix, right and left, joining each side of the skull across the upper back to the opposite shoulder, and then around the ribs to the front to cross again at the level of the navel to the hip. From the hip, the spiral line passes like a jump rope along the anterior lateral thigh and across the shin to the medial longitudinal arch, passing under the foot and running up the posterior lateral side of the leg to the ischium and into the erector spinae myofascia to end very close to where it started on the skull. As you can see the picture beside the spiral line and how it runs in the human body. Here we have the demarcations for the spiral line on the human body, and as you can see how the line encircles our whole body. Lastly, we have the deep front line, interposed between the left and the right lateral lines in the coronal plane, sandwiched between the superficial front line and superficial back line in the sagittal plane, and surrounded by the helical spiral and the functional lines. The deep front line comprises the body's myofascial core. Beginning from the bottom, the line has roots deep in the underside of the foot, passing up just behind the bones of the lower leg and behind the knee to the inside of the thigh. From here, the major tracts passes in front of the hip joint, pelvis and the lumbar spine, while an alternate tract passes by the back of the thigh to the pelvic floor and rejoins the first at the lumbar spine from the psoas diaphragm interface. The deep frontal line continues up through the rib cage along several alternate paths around and through the thoracic viscera, ending on the underside of both the neuro and viscerocranium. Here is a demonstration of the deep frontal line and the myofascial tracts on the skeleton. So here we have a dissected deep front line showing the continual tissue connection from toes via the psoas to the tongue. Chasing the pain. It reminds me of prominent physiotherapist Diane Lee's saying, "It's the victim who cry out, not the criminals." Taking care of the victims and collaring the local thugs is addressed by point 1. Going after the big shots is a job of point 2. It is a metaphor used in context of our body. When we have pain at a site, it means that a particular area is the victim and we need to find out the real culprit or the real problem. So the knowledge of fascia helps us to connect the whole body into one. So if there is a shoulder pain, our brain will search for problem in the ankle as well because of the open possibilities. So in the end, I would like to say fascia isn't the latest answer to everything, but the question it seems to be answering. As growing research sheds new light on the old theories about structure and movement, are revolutionizing the way we treat the body clinically, athletically, individually, and holistically. Thank you so much. I hope you like my presentation and I wish that it could help you for learning about fascia.